And my part is now to move to the two other groups, which are not so very popular in talking about and very difficult in managing groups 3 and 4 of the Poseidon. And we also have another polling questions for you. So just scan again, or if you are already scanned in, then it's okay. So patient of Poseidon group 4 will benefit from recombinant LH supplementation because A, they are older than 35 years. They will have less pregnancy loss and higher live birth rate. They will have more oocytes, or A and B are the correct. Okay, almost 2/3, I think, had a good answer, but there are some other opinions. And the correct answer was A and B. And we shall look a little bit more about the evidence just in a short time. So in one of my visits to China as a speaker, in the lobby of the hotel, I saw this group of ladies. They all had this red stuff written Poseidon on both of them. So I was very curious to see what it is. And I asked one of them, who are you? And she said, oh, this is just a tourist group. And the group of the tourism is called Poseidon. I said, it's interesting. I'm founding member of the Poseidon group. So it's interesting. So that when they heard about it, they said, oh, can you tell us about if you want to have babies and so on? And then I tried to figure it out. And one of them figured to be to conflict with group 3, and the other one was like a group 4. And so we were discussing the possibilities. And I said, okay, if you will have only 3 or 4 eggs, like in Poseidon group 3 and 4, you still will have different prognosis to have a child, and even the cumulative live birth rate, as you can see here, will be different if you have different number of oocytes. So they ask, well, why it is, and as I told you before, we have problems with the euploidity of the oocyte. So if you are less than 35, you have a different euploidity than if you are over 35. And we have seen this already before. But within every age of group, as we learned from Sunkara's paper now almost more than 10 years ago, 12 years ago, in every group, each oocyte that will be added up to a number of 15 will increase significantly the probability to achieve a live birth. So numbers of oocytes, even in this very difficult group, is important. So what kind of strategies can we have for this group? Well, we shall look at pituitary suppression regime. Does it matter what we use? Stimulation approach using conventional, mild stimulation, natural cycle, double stimulation. What kind of adjuvant we can use? Androgens, LH, growth hormone. And let's start with the comparing gene-RH antagonist and long agonist. Well, in poor ovarian responder patients, there have been a meta-analysis by the Cochrane database. And as you can see, there is no difference if you use in this group of patients long agonist protocol or antagonist protocol. So ongoing pregnancy rate, which is used in the Cochrane database synonymously to live birth rate, was not different within the two. So it is no problem to use one of them. Concerning the dose of the gonadotropin FSH, It has been shown in the same Cochrane database that concerning the number of the oocytes, it is probably better to have around 300 units of FSH compared to just having 150 units in this group. But going above 300 units, there will be no benefit of the increasing the number of the oocytes. So in the clinical work, we shouldn't actually use more than 300 units of FSH for stimulation. The same goes also for canceling rate, and you can see that there was higher canceling rate if the dose was less than 300, but there was no difference over 300, and the same with the live birth rate and ongoing pregnancy rate. No difference in the outcome. So what about mild stimulation or natural cycles? There have been several publications. This is just one of the overview by Nikos Politsos to show that this is actually not the best group for this kind of treatment because the probability to have a live birth rate were extremely low. Dual stimulation, we shall hear more about that by Alberto Vaiarelli later on, but several of the studies have shown that repeating a stimulation in the same cycle will increase the probability to have euploid blastocysts and increasing the probability within a short time to achieve a pregnancy and a live birth rate. So the benefit is to shorten the time until the live birth will occur. Now, the big question is the androgens. And as you know, androgens can be important in the follicular genesis in two different parts. The one which is very at the beginning of the development of the follicles and maturing of the follicle, which is called initial recruitment of follicle. And here it is important because it will have a significant influence of the decreasing the atresia of follicle. The other one is the cyclic recruitment by improving the sensitivity of the FSH receptors on the granulosa cells to the FSH. So the recruitment at the beginning of the cycle, menstrual cycle, will be higher via the androgens. The initial recruitment, that happens like 3 or 4 months before. And this is important to understand how you want to use the androgens and when it is helpful and when it is not helpful. Now, the most common androgens that have been used were either DHEA or testosterone. DHEA is affinity to the receptor is low, is a weak androgen compared to the testosterone. And the studies have shown that there was no increase in intrafollicular level of testosterone or increase in androgen receptor if you use DHEA, which is very different if you use testosterone. This is the latest meta-analysis looking on DHEA. And you can see that concerning the number of the oocytes, metaphase 2 oocyte, clinical pregnancy rate, live birth rate, no difference if you use DHEA. Most of the studies that have shown that there was a benefit were more anecdotal or retrospective, and it is difficult to take them. So there is not sufficient scientific evidence that using DHEA will benefit at the end of the day the patient. Advantage is that it's low cost and there are not too many side effects. You have to use it many months in order to see some effects. But at the moment, we cannot say that we can suggest to use it in daily clinical work. So what about testosterone? So this is also the latest meta-analysis in 2022. And in testosterone, we can see that there is some benefit in the oocyte number and clinical pregnancy rate and live birth rate. But if you look at the number, sorry, this is moving by itself. If you look at the number of the patients included, it's very low. So the question is, can you implement from a very low number of observations and to give clinical suggestions? So here it was needed to have more, and also there were different times and different dosage of testosterone in the different papers that have been included. So an RCT has been started many years ago by Nikos Politsos called T-Transport study. It was a multi-center study in, I think, 5 or 6 different centers in different countries and different continents. And it was powered to look if there was a benefit. So I think they needed to recruit something like 450 patients, Bologna criteria patients, and look, and they used a good amount of dose of testosterone and started about, I think, 2 months before starting the treatment of the stimulation. And Nikos presented it at the last Este and informed us that the interim, after they have recruited 2/3 of the amount of patients that they had to be recruited, the ethics committee stopped this treatment, this study, because there was no difference in the outcome between the treated patient and the non-treated patient. And it was a double-blind RCT powered state. So at the moment, we don't have, even in this kind of a study, evidence that using testosterone will benefit the outcome of this group of patients. And as I said, the problem is usually in all the studies that we have seen, the starting point of the testosterone and the amount of testosterone was kind of the testosterone, and there is a huge misunderstanding there. So even here, I think it needs to be a little bit more evaluated. Maybe the 60 days was not enough in order to interfere with the initial recruitment, and you have to do it even longer. But most studies, maybe a little bit more decided, probably will be needed to convince us to use it. Another way, by the way, to indirectly use androgen is what we call LH priming. As you know, the problem, especially with advanced maternal age, is that the TICA cells have less and not very active receptors to LH, and the LH by itself is less bioactive in this place because a different isoform with advanced maternal age. And it has been shown in a study from the Bologna group that if you use LH after a downregulation in a long agonist protocol for a few days, you can increase the activity and the sensitivity of the receptors on the TICA cells. So more androgens will be produced from the TICA cells, which will affect the FSH receptors, so the recruitment might be better. And also the competence of the oocytes will be better. So what they did was to start 150 units of recombinant LH for 4 to 5 days. And only after they started with the recombinant FSH, there was an increase of 1 oocyte compared to the previous cycle. but there was a significant increase in pregnancy rate, implantation rate, and live birth rate, which means that upregulating also paracrine system by this LH priming will affect the competence of the oocytes that have been recruited after that and led to a higher implantation and pregnancy rate. Now, what about growth hormone? Also here we have a lot of information, a lot of them not very stable ones. Growth hormone has its own receptor on the granulosa cells, and stimulation of IGF produces in liver and the ovary. And growth hormone is an important regulator of ovarian function. So it works like a co-gonadotropins during the stimulation of the ovary. And because of that, it was thought that using growth hormone might improve now outcome of treatment in this very special group of low number of oocytes. And there have been, as I said, many studies, usually very low number of observations per study, use different dosage of growth hormone, again, different lengths of treatment. So it's not very homogeneous, all the studies. And I just chose this one because this looked at outcome of low prognosis patient according to POSEIDON criteria, and I thought it was interesting. And they mentioned that they could see a higher live birth rate or clinical pregnancy rate in all the 4 POSEIDON groups. But we have this latest meta-analysis here from 2020, and they say that they could reveal higher number of oocyte, especially metaphase 2 oocyte, and fertilization rate. But they say at the end, in the conclusion, that although some improvement in the reproductive outcome in poor responders could be observed, there was no difference in the live birth rate. So using growth hormone, according to this meta-analysis, doesn't show a difference in the live birth rate, which is actually the end point that we are looking at the end of the day. So here again, the problems is, and there is still not a good powered RCT to do the study and to inform us, shall we use growth hormone, and if yes, in which way to use the growth hormone, and not having all this blurred and different unhomogeneous approaches. And what about using LH? And Carlo already mentioned the ESPART study, which was on Bologna criteria aligned poor responder patients. And this has shown, of course, that using LH will not increase the number of the oocytes in the stimulation. But when they looked at the post hoc analysis, and they looked at the more severe groups of the Bologna criteria, which are the most advanced maternal age patient, they did see a significantly lower pregnancy loss and a higher live birth rate if LH was used. So again here, the use of LH will increase the competence of the oocytes, although it's not increasing the number of the oocytes. So this is probably why this effect has been seen, again, by upregulation of paracrine system and growth and development factors during the follicular development. So the competence of the oocyte is different. And again, a meta-analysis published a couple of years ago did show that if you use recombinant LH in the stimulation, especially when we look at the group between 35 and 39, you see an increase in the implantation rate and the pregnancy rate. If you, in this meta-analysis, look at the general group over 35, you will probably not see a difference. It doesn't mean that it doesn't work. The problem here, if you have patients over 40, they have a very high aneuploidity rate. So the aneuploidity rate will impair the implantation and the pregnancy rate. And that's why it will dilute your statistical results. In the age 35 to 39, the aneuploidity rate is lower and then the over 40. And then you can see really the effect of LH because the aneuploidity doesn't play a role. So this is the reason why we have these two different outcomes. So how we treat patient Poseidon 3. So these are patients with low reserve, but good quality of oocyte because of the age. And because of that, we can use, as I told you, either long protocol or antagonist protocol. If you use antagonist protocol, it's important to do a pre-treatment either with estrogens or progesterones in order to have a more a close in the development of the follicles. Because of the high FSH and the low AMH in the luteal phase, there is an acceleration of recruitment of some of the follicles. So you will have a desynchronized follicles when you start treating. So using in the antagonist protocol, estrogens or noradjustrone will be helpful to synchronize the follicles. Of course, this is more easy than with a long agonist protocol. Stimulation should be used with recombinant FSH just to increase the probability to have a higher number of oocytes. And it can be used with recombinant LH if additionally we might think that there is also an sensitivity problem, polymorphism of receptors. We can add the recombinant LH. We can go for fresh transfer. We can use dual stimulation to increase the number. But even with a smaller number of oocytes, because the higher euploidity rate of the oocyte, we can be successful in this group. And that's why you saw in the cumulative live birth rate in the big validation that this was actually the second group to have a high cumulative pregnancy rate. Now, Poseidon group 4 is a poor reserve and poor quality. So you have now the bottom of the cellar here. And so in this group, we can use again either the long protocol or the antagonist with the pre-treatment for the synchronization. In this group, because of the advanced maternal age, it is probably beneficial to use also recombinant LH to have a maximum development and competence of the oocytes. I put a question mark of using androgens, growth hormones. Dual stimulation will be, of course, one of the ways to increase the number of the oocytes in the shorter time. And Alberto will talk to you a little bit more after the break. And fresh embryo transfer is, of course, possible if you have been lucky to find within the first group a euploid blastocyst, but otherwise you can, of course, accumulate and do frozen embryo transfer later on. Of course, it is good to use the calculator because the calculator will help you to make decisions in the management, what to do and what will be the optimal number of oocytes. Concerning the information the couple is giving you, but also what kind of sperm you are using, the fragmentation of the sperm, it's ejaculated or testicular sperm. All this might affect the decision of the number of the oocytes that you want to achieve and how do you want to manage to get to that point. And this is helpful then to counsel the patient. It's very important to counsel the patient, especially this group of patients, because you have to tell them something about the journey they have to go. So they have an AMH of 0.2, and you might achieve maybe only 2 or 3 oocytes in the stimulation, and the euploidity rate is 10%, then you have to tell them that they will probably need more stimulation, either via dual stimulation or repeated cycles, and it takes longer time unless they had collected the checkpoint and found the oocyte within the first one already there. But if they are unlucky, it's oocyte number 20. And then they maybe need to do 5 or 6 cycles to get there. And this is important to talk about it at the beginning, because if the patient is counseled at the beginning and they know what they have to do, they are not so frustrated that if you don't tell them, and after the first cycle say, okay, so why I'm not pregnant? And my neighbor is pregnant, and the other center, they told me that they are pregnant, so I go somewhere else, because they don't understand why they are not pregnant. So the consultation is very important, and it helps us also to establish the management from the beginning and to know what we want to do. So it's helpful also for the clinician, but of course also for the patients. And this is just a summary for all what I have told you now. So I will not repeat it again because of the time. We are running a little bit late. So thank you very much, and some pictures from Hamburg.